When you sign into the internet, do you have to do @ComNet?
Yeah, I didn't have to sign in. I was already in.
No, I don't know why
I think a lot of people got kicked out.
Is the nursing pin, right? So you got to keep your eye
might
on
do
the
the same thing I
prize,
did.
which is coming. When's nursing pinning? Baby. Prize. This is awesome. Okay? So what we're going to do first is go through Blackboard a little bit. I want to tell you some of the biggest challenges this semester is communication. And why is that? Because we only see each other once a week. While you may say, rah, rah, hey, hey, not so much, because now you have to be on Blackboard. If you haven't gone to messages before, some people are laughing. Some people are like, what are messages? Okay, I'm serious, because I know some of you admitted to me I've never been on messages, never checked it. It is going to be a challenge for you. We communicate through Blackboard, because we only see each other once a week. It's a beautiful thing, but it can be a very challenging thing for you as well. So make sure that you're checking messages. Make sure that you're looking at the discussion board. We reserve announcements only for the extreme. Otherwise, it's all in messages and it's on the discussion board. Otherwise, we'd be blowing out announcements to you guys all the time. All right, so if something's on announcements, it's extremely important, time sensitive. It checks all those requirement boxes for the faculty to say, yes, this should be an announcement. All right. So we're going to go through this. The weather was great this morning, huh? Depending on where you live. So do you all have my comment on your phone, on your computer, so it rings your telephone, your home phone, wherever it is, so you know when there's a delay, when there's a cancellation. If you're not signed up for my comment, you need to be, okay? We follow whatever the college says, right? I don't have that ability to cancel class, end class early, clinical, etc. If we have an exam and there's a delay, we will start at whatever that time is that the college opens. Now our class starts at 9:30. For the most part, usually the college is open by then. Occasionally they might do that 10 a.m. It just means instead of starting at 9:30, we would start at 10. Now that's something that's worthy of an announcement, so we would probably post out an announcement as far as that as well. All right. Clinical. It's important that you have a way to contact and communicate with your clinical instructor. Oftentimes it is with a text message or a cell phone. Please don't abuse that, right? As far as after hours, weekends, the use of knowing those phone numbers. It's meant to be a communication during that clinical time, any important phone tree information that needs to occur. Depending on what the school determines as a delay or a closing is going to depend on your agency, whether or not you're going there, you're coming here, you're doing something remotely, etc. All right? Too many variables to even get into if this, then that. Okay? That's the big communication, which is, to me, the most important. The next thing is Castle Branch. Okay, you have to have Castle Branch up to date. If there's anything outstanding, you cannot attend clinical, not even orientation. There are a handful of students that have some things outstanding. Please check it today. Okay? Whether you need to go and get a physical at the walk-in, a TB, a Hep B, whatever it is, right? Get it done. Be mindful of when your CPR expires, because I know that might come into play this final semester. That's part of the requirements. So pay attention to Castle Branch. Get on a routine basis this or put an alert in your phone, on your calendar of when something might expire, so you're on it. The last thing you want is a, you can't come to clinical. That's not acceptable, right? Okay. So let's go through here now. I'm sure everybody knows about announcements. Our calendar tab, obviously I would think by this point you've seen the calendar. I'm not going to go through it, however, I do want to point out one thing, and I should have brought mine down, so I guess I will open it, is on February 20th. February 20th. Class is actually extended. Each one of these topics is 1 hour, which is why we extended the class. Now, yes, we can try and shorten it and cram it in, but it is in your best interest that we extend class that day. So class is extended that day. Otherwise, as we go along, you will see, we'll kind of go through the calendar. This week, tomorrow morning, 8 a.m. is the dosage calc exam. I know there was a question on the discussion board regarding, can we find out what we got wrong on the ATI practice dose calc? I just changed that setting, so check it out, whoever sent it, I think it was Nicole. And let me know if it worked or not, because if it didn't, then I'll have to go back in there. I thought it should have given it to you, so I don't know what the deal is with that. But it's the same questions that are literally on your practice paper exam. Okay. Information for dosage calc is posted in that exam information tab. If you need a computer and you are not in a room that has computers, which is to the computer lab, or 125, right, there's a rack of computers in there, then you need to contact me, send me a course message, so that way there I can move you to an appropriate place. Good. Shout out to Charlotte Hungerford, because their orientation is on Friday. I believe Professor Anderson has contacted you and sent communications about that. So for Charlotte Hungerford group, on Wednesday, you have no commitment. Your Wednesday has been moved to the Friday. It's only Charlotte Hungerford. Things that are in red are kind of highlighted, due dates, etc. Mental health first aid training. Oh my goodness, I am so proud of you. I think 96 of you signed up for mental health first aid training during that semester break, as far as had made plans for whenever the options are. So thank you so much for that. Clearly you were looking at Blackboard and listening to the messages and putting that into your schedule. There is, it is a requirement that's due by March 24th. And additional options were sent in your course messages. So if one of those 4 options that was initially announced to you were not really meeting your needs, then there are a couple of other classes that were offered, and that is in your course messages. I think one of them's even during spring break. Okay.
Sorry, March 30th.
March 30th. Okay. You got a question? Where?
Sorry, what was that?
Oh, there you are.
Does meeting us to send the certificate, or do you know
Yeah,
automatically?
so let me just finish with the calendar, and that's all I want to say right now.
Is it a list? So they have you do some of the stuff online before?
Joint conference. So the joint conference is during your clinical hours. Remember how we came back here for our joint post-conference? That's what that is. So we're doing that a couple of times. Okay?
Is it like up to
No, it's not the joint commission. The schedule for tomorrow is up here, as well as the skill demonstration. All right? Skill demonstration, so what does that mean? Tomorrow you're gonna meet and greet with your clinical instructor, so you'll get whatever it is you need to know for coming in on Wednesday, what time you're meeting, where you're meeting, etc. Hand in any paperwork. You know, in the clinical tab, we'll go there, there's a section for each agency. There's tons of paperwork, right? Be proactive, get that done today, so that we're there tomorrow. When you come in, you can hand it into your clinical instructor. Then, you're going to do the skills demonstrations. You're gonna work with a partner, you're gonna time each other and do the skill. This is a great way to see how am I doing. Did it take, it's supposed to take me 5 minutes to do that skill, but it took me 15. Well, clearly that means you need to practice, right? So practice, all right? We're expecting that you're proficient in these skills, you've been validated in them, and you were performing them last semester, so come back with that in place, that proficiency. All right, we're not reteaching during that time frame. All right, so that's everything in the calendar tab. Getting started, please go through each one of these sections, all the consents, right? We're not supposed to be recording unless I have everybody checked off saying that they consented to recording, checking off the syllabus. We're okay. I guess, actually, I should say welcome to Professor Nobilio. Shame on me.
I said, I feel like this is deja vu. Last year, when you were all coming in, you were freshmen, look at you now. So excited.
So our faculty team is the same as last semester, but we've added Professor Nobilio, Professor Kelly, and Professor Anderson. Professor George will be here tomorrow, earlier today, actually. So make sure you go through that Getting Started tab. Class content, no different. It's organized by your dates, okay? Discussions. I tend, and again, there's many ways, but a quick way to make sure that you're not missing anything is these unread posts. Look at, oh, I didn't read these 7 messages. Oh, I didn't read this one. You can click right on here, or you could click on questions about this course, and it shows you the individual threads. Okay? Questions on discussions, you can reply, you can answer, help each other. Questions? Okay. Messages, same thing, right? Send messages through the course. Clinical. Here's your clinical agency information. I know you already saw your rotation schedule, so I'm not going to click on that. But certainly here's the clinical agency rotation, or agency information. Don't worry about what anybody else is doing. Worry about yourself, right? What your schedule is, what your responsibilities are for that agency, because they are different. What the commonality is Castle Branch. So whatever's inside this folder for Bridgeport Hospital, that's what you need to do and have prepared, whatever it says, whatever's been communicated. I believe Professor King is there, so that's what the expectation is, that you would hand all that in to her tomorrow at, what, 9 a.m. when you first see her. Right? Every hospital is listed here. There are some other things here. Make sure you take a look at the medication policy and resources for clinical. So there's some helpful information here, all right? Let's see, your lab skills and resources, all your videos, and the lab interactive calendar. Professor Loeb's in the lab. Same as last semester, so you could book an appointment through there or Outlook email her. Exam information, here's your information regarding exam 1. Dosage cup, tomorrow morning, 8 a.m. Okay?
All the exams are in an hour before lecture, like 8 a.m., all the exams are
No, only because dosage calc is different, right? Dosage calc is our class time for our unit exams is going to be the class start time, which is 9:30, except for the final exam. And it should say that on your calendar, which final exam, 8 a.m. is in red. So that is an exception, okay? Dosage calc exam number 1. If you get 100, you're gonna get 2 points added to the unit exam one. So guess what? We want you to get the 100. You want to get the 100, which is why in that Getting Started tab that's been open since December, there is a module that's all on dosage calc. Professor Kelly came in last Thursday and offered a dosage calc review, right? Take advantage of these opportunities to get those extra points.
How long is the test?
10 questions, 30 minutes to take the exam. Okay? If you do the practice exam, and feel comfortable with that, you should, in theory, be able to take your time and get 100 on the dosage calc one. No different than the fall semester, right? They're very similar. I don't know how else to say it. Okay? Graded assignments, I know you want to hear about this. Now, the one thing I'm going to say is take a deep breath, right? Because this is the whole semester and it gets really overwhelming when you look at the whole semester. No different than when you came in the fall, it was extremely overwhelming when you heard everything that we were going to do. But guess what? Right? You did it. So, we do have those dates due throughout the semester. Pay attention to them, plan accordingly. It's great that we're here one day a week. There's still the same amount of work. So don't think that I've got Thursday off now to do whatever. You need to study. Now whether you study on Thursday or Friday, Saturday, Sunday, whenever, that's up to you. But manage your time accordingly. Block it out on your calendar. So the dosage calc exam, you have 3 opportunities. If you're not successful with the minimum grade of 90, then unfortunately, you're not going to continue on in the program in this course. We want you to get that 100, so you get the 2 points on the first time for that unit exam grade. If you do need to take the dosage calc over again, the dates are on the calendar. I think it's like the next 2 Mondays for number 2 and number 3 prior to class. There will be 3 reflections. The first one's due February 2nd.
I think
You
so.
can do that anytime now, right? Because you're really not going to have that much clinical. Wait till after you do your skills, so that way there you can kind of wrap your head around, okay, how am I thinking clinically right now? Where is it I need to focus? What are my strengths? Where are some challenges and I need to focus my time on? There'll be a mid-semester and then the final one. The clue, we're going to be doing a clue every week on your patients, no different than what you have been doing, but you will submit one to Blackboard that's graded, all right? And that needs to make sure that every column is satisfactory. You need to do that in order to successfully pass the clinical component of the course. Now I'm here to tell you, don't wait till last minute. I bet you I can count on 1, maybe 2 hands, but I doubt it, that y'all waited till the last minute. Don't do that. It's the same clue. So within 3 weeks, first month, determine the patient and do the clue. Once you determine your patient, it's due 2 weeks after you select that patient. You're going to do that with your clinical instructor. If the clinical instructor says, hey, you this patient, you should do the quill on this patient. Trust them. That means there's a lot of good information there, and you're gonna be able to pick those priority problems. You got something to pick from. Go ahead.
My favorite thing, I was looking for the food thing now, where is it in Blackboard?
It should be on the clinical tab, so.
Unless I'm missing.
No, I'll look, because maybe it's in, who knows? It's possible, so I'll look for that. Because to me, it's clinical paperwork, and you're right, it's not here. So it's probably it, it's a click of a button.
Okay.
So let me write that down, I'll open it up. Thank you. All right, so that's the clue. So everybody's gonna have a different due date on that clue. Do not wait, all right? As we progress throughout the semester, and certainly towards the end of the semester, guess what? You're gonna be thinking more like a nurse, and you're gonna be rattling off those priority problems and interventions, and then we're not gonna make you keep writing everything on the clue. So the sooner you get there, the less writing, typing that you're doing. So when you're in clinical, focus on this. Use your time wisely, all right? Work together. Process recording. I'm going to let Professor Anderson talk about that, and I believe she's talking about that today in class. But there's also a process recording assignment, and that will be uploaded to Blackboard as well. So she'll provide information on that. And then there's a lot of standardized exams, and all I can say is I'm sorry. I don't know what to say other than that. Okay? It is definitely more than last semester because this is the end of the program. When you first came into the program, you did a critical thinking exam entrance. You'll do that critical thinking exit during one of your on-campus days towards the end of the semester. There's also going to be the concept-based number 4 exam, and I believe that's going to be your last agency day. I want to say it's April 26th, so it's built into your clinical time. So you won't be coming in extra for that. The ATI Practice Comprehensive Predictor. So the Comprehensive Predictor is something that is basically like your NCLEX exam. So we want you to take a practice one by March, nobody knows? 23rd. March 23rd.
Are these gonna be in the new style?
Well, that's a great question, because the comprehensive predictor, the proctored one, does have NGN case studies built within it. I'm waiting to hear back from ATI to see if the practice one is going to be offered with those case study questions. So I don't have an answer for you on that right now. I don't see it as an availability to you. Some more info on that, but the comp predictor, don't take it yet. Wait a little while, wait another month or so. But then take that practice comp predictor so that way there you get the sense of what NCLEX is going to be like. From that, and we're going to talk more as the semester goes on, you can remediate in certain areas. Take that test very seriously, because it's going to give you some insight of where you need to start focusing your studying. Yes, we want you to pass this course, but we want you to pass NCLEX as well, right, and get a job. We have those 3 main goals for you. Go ahead.
I emailed you, I don't know if you got it, but in ATI, I don't see anything that specifically says comprehensive predictor.
Oh, I put the, in this tab, I probably didn't answer you, and I apologize for that. In the comprehensive predictor tab, I did put the name and the ID in here.
Okay.
Okay? But again, I would wait a month before you're doing that.
So you would, you would take it initially, you wouldn't get the same exam, but you guys would deviation if you want to take it again.
No, so this is a practice exam, it's available to you now, but I would get through all that behavioral health and maybe some of that oncology, part of that oncology section that we're gonna be going into, and then take your practice exam. Closer to that due date, within 2-3 weeks from that time, all right? Then if you find that you're really low in one particular area, you might wanna do some remediation on that. Again, we're not gonna even talk about that piece right now because that's another month. You don't need to know about that yet. Okay? Yes?
So again, it's premature in the semester to focus on it.
Right.
But the contradictory results, the proctored one, when the instructor teaches you the NCLEX review course that you've already paid for, it's in your fees. It's on the calendar, so please don't schedule a cruise for yourself and come, because you've already paid for it, and it's a good review. They look at the results of the proctored contradictor and say, as a whole, they'll look at the results and notice you're a little weak in maternity, or a little weak in psych, or a little weak in pharm, and it's supposedly more of a custom review. So the proctored contradictor you're gonna take seriously. What we've noticed over many years we've been using ATI is there is a correlation to students who don't pass NCLEX, that they do have a lower grade on the contradictor. So it's also a good measurement for you to say, how prepared am I for NCLEX? And you're taking it in the end of April, early May. So then you have, whenever you plan on taking the NCLEX, you have that many months to really tailor your study, your studies calendar or whatever. So you'll hear more about it, but it is connected. The instructor who's gonna teach your NCLEX review class here on campus, and it's on your calendar, does look at the results.
And everything she was talking about is the proctor. So you're gonna do a practice, then you're also on the calendar gonna come back, I'll look at when it is, later towards the end of the semester, May 2nd, and do the proctored predictor, which that is everything that she just said. Thank you. Go ahead.
I tried to make a discussion, but it wouldn't let me. For the transition course, the NCLEX classes, it says to sign up because there's limited spots.
So I'm actually gonna let Professor Mobilio talk about 226 in just a second.
Okay, yeah, I'm just gonna see the links.
Yeah. That's the transition class. All right, so here's your mental health first aid certification. You would upload it here to answer that question. Right, all the links are in here in graded assignments. So something that you need to successfully pass this course, to complete it, whether it's a part of your academic grade or part of your clinical satisfactory, non-satisfactory, would be in this graded assignment tab, just like it was last semester. Okay, go ahead.
When are we gonna start integrating next gen on our exams?
Great question. More to come. More to come. We will let you know. We'll start with practice and then incorporate into unit exams. Okay? My grades, anything ATI information related here, and NCLEX. Again, not something you need to look at, but there's just general things regarding NCLEX here. Okay? Questions about the course? Please focus on communication, keep your Castle branch up to date. We expect questions. So now we're going to go on to 226, which is a completely separate entity, and you have your own instructor for 226. So don't email me about 226, because I'm not your instructor. Don't email Professor Kelly, and don't email Professor Mobilio if she's not your instructor, right? there are 4 separate units with an instructor assigned to that unit.
Right.
Yes, does everybody understand that?
Exactly, I'm gonna talk about that, right, exactly right.
Sorry.
Yes, no problem. So wow, it's so good to be back to see all of you guys again. So yes, I am one of the instructors for 226. There are 3 other instructors, and I presume you all have seen the course. You've sort of been in a little bit. And so now it's time to learn a lot and to look around the course. So we put some things up there, and we've been trying to get the class together. It's a little bit different than last year. So if you are in touch with someone who just graduated and they're telling you about 226, this class is a little bit different. And I'm going to tell you, I'm just going to give you some highlights about it. I'm not going to get into great detail. First of all, there are 4 different instructors. So if you have any questions, email, go on that discussion page. We have that also, and put your question out there, because if you have the question, chances are others have it as well, and we can all communicate. So the class is 100% online. The only communication that will take place is emailing or the message center, either one. If I'm your instructor, I'm fine with either method. I get back to you quicker with the email, but I do check the messages also, we all do. So if you have a question, just contact us in that regard. There are going to be weekly questions. So what I suggest is everybody go into that class today and look around the course. Look around the Getting Started tab. There should be announcements. I know for my class, I posted an announcement as to basically how to get started with this. Go on to Getting Started, look through all the tabs. There's a calendar as to when things are due. There's all the assignments are there, the topics. So basically what you're going to have to do is answer one of those questions each week. So we have divided each group into cohort or group A or cohort group B. So know which group you're in. The very first week, everyone is doing the first question. The questions are due. Mine are due on Thursday. I think some are due on Wednesday or Thursday. So they are due the week of the date that's posted. So the date that's posted was for January 23rd. This week's assignment is due on probably Wednesday for most of you, Wednesday or Thursday. See when your instructor has it due. Mine are due Thursday, but I know some are due Wednesday. So check to make sure, posts, I know I've gotten a couple of posts already. They're great job on them. And this week you do not have to respond. The following week, what's different about this course versus last year's is that last year's, every week, every student had to do a post and a response. This class, you just have to do either one, depending on your cohort. So if you're in group A, most likely, you're going to have to do a post next week. Remember, everybody's doing a post this week. Next week, only group A is going to do the post. If you're in group B, you just have to respond to the post. Following week, we switch. Following week, group B is going to do the post, and group A is going to respond. So basically, we're cutting down your workload by half. Thought you might like that. We like it too. There is a rubric for how we're going to grade your posts. There's a total of 65 questions. I see some of you are probably in the course right now. And there's a total, okay, if you're in my course, I have to change the rubric. I'm having some IT problems with that. The rubric is there. When you go to the grading rubric, only totals up to, that's last year's. So it's the 2022 grading rubric. We've changed it a little bit, not much at all. We've taken away the APA format, which is huge. We've taken away the paper, which is huge. Right. So I have to change the rubric, but the rubric's in there. And yes?
You took away the APA format?
Because the syllabus says that
The syllabus says that the APA is, so go by the rubrics.
And so does her video.
Whose video? Professor Rivera? Okay, well, I'll check, so check into that, but follow your course.
Two references, they still want us to do references.
Two references, yes. So whatever the rubric says, okay, whatever the rubric says, we're gonna upload it. I'm going to, my rubric is in there. If you were in my course, my rubric's in there. Under rubrics. It's just not, I can't upload it into the grading center. I'm having trouble, I'm gonna work on that today, actually. Okay? Yes? I was gonna address the links. Brittany, you had talked about the links. So my links, I believe they work. I had a little trouble uploading them, so every instructor's gonna upload the links. Mine are under course content. If your links do not work to register for that, the little class, Dr. Gabriel is having a little bit of a discussion class on the NCLEX preparation, that what you need to do for that and for recommendations. It's gonna count as a week's post. It's gonna count toward your 65 points. So it's mandatory. Please attend, sign up for one of them. Look for the links. I know mine, it took a little doing, but mine are there. If your instructor's links are not working, send your instructor a message about that. Yes?
So, when was that changed? Because I recently just looked at the rubric a few days ago, and.
When was what changed, the APA?
The APA, yeah, because it's 200 to 300 words, and you've got.
Right, no, there are so many words, and it's more about the formatting of it. So you still have to cite. That has not changed. It's formatting within the paper that's changed. The formatting of the APA, the double spacing, all that, when you do a post. You still have to cite, absolutely. So that has not changed. The citing has to be APA, yes. But as far as the formatting within your post, does not, you're not going to be graded on that. Okay, so just look around, read it through. I'll take a look at the syllabus. I thought we had changed some of that. I'll take a look at it. But the main thing is the rubrics for your posts. Yes?
My question is are the rubrics going to be the same for each instructor?
Yes. The rubric is the same for each instructor. The course is the same for each instructor. The only thing that's different is the due date. Some are Wednesday, some are Thursday. Okay? So look around the course. Send a message if you have any questions. Any other questions right now? Thank you.
So the only thing I want to say is if you have a due date on Wednesday, this is where it can become a challenge, right? Because your Monday, Tuesday, Wednesday gets kind of full with clinical. Please don't be working on 226 in clinical. That's not appropriate, right? When you're in clinical, you need to be focused on clinical. So this is where this semester can become a challenge, time management.
And if you have extra time and you want to work ahead on some of those questions and posts, feel free. You can work ahead. Just make sure you're doing the right post. When it's your week to respond, you don't want to be doing a post. So everybody is doing the question this first week. They're doing the post. Next week, we start breaking it up into groups. Okay? Your group A, you start your post. Group B does the response. And then you've got a week off from the post, and then the following week. So just make sure you're doing the right question.
Follow directions. If you need clarification, you ask that instructor, right?
Are the posts due at the end of the day?
Are the posts due 11:59 p.m.?
Yes,
Yes, they are.
You do not have to do a response for this week because you're only doing, everyone's doing a post. Okay, so no response for this week. You're only gonna be doing one activity a week. One activity a week, so it's either gonna be a post or a response. Okay?
If you're on the response week, is the due date for your response is obviously different than
Sunday.
the post, right?
The
Okay.
response is due on Sunday because the post has to be in by Wednesday or Thursday, so the response has to be in by Sunday at midnight. Yes, you can choose who you want to respond to. So like my group right now, this week, there's no response. I think somebody did do a response, and that's great. No extra points, but very nice. Next week, if there's a response up there, somebody might want to work ahead, and you were scheduled next week, you're in group B, and you're going to do a response, and there's somebody who's already posted, and you want to go in and reply to that, you can reply to anyone. Okay?
You only have to reply to one person?
You only have to reply to one person.
Can everybody respond to that one person, or do you have to? You know what I'm saying? Like, or does everyone have to get a response for every
I'm
post?
guessing that in the rubric, you have to offer new information. So in all honesty, the sooner you respond, it's
Yeah.
probably a little bit easier, I'm thinking. But I don't, I'm not.
Yeah, don't wait.
Are we good? Any questions? We're going to get started. Yes, there's a lot that's happening. Don't worry, you've got your calendar. The key dates are on there. We're going to be reminding you as usual and help you through, navigate your way through. Focus is communication, as well as with Joseph Health and Castle Branch skills. Good. Welcome back. Can you hear me now? I don't want to hold it now. If you have not signed in, make sure you sign in and get into or with these.
I can't hear you.
Hello? Hello?
Yeah.
All right, I'm just curious. Make sure you sign into the attendance today and tomorrow at least if you have not gotten these handouts. They're really good for clinical. I know a lot of you brought your books in preparation. I was so happy when I first came in. But these handouts are going to be good for clinical when you're doing your process report. So make sure you got it and make sure you also get a copy of the grading report. All you need to put your initials on the assignment sheet. The attendance sheet, so we can make our class, okay?
I know
We have a lot of material to cover today, but we also have a couple of hours for you guys on Thursday. So anything that's not covered today will cover on Thursday. I am not going to rush class.
I just uploaded my show.
Or take a minute or you have
Really? Are we gonna do it? Are we gonna do it then?
What?
I know. I had to get it done because I was like,
I can see Thursday. Next Monday. No, tomorrow. Did I say Thursday? Oh, no, we're not doing Thursday. You guys want to talk? Tomorrow I have another, I'm still in fall, so tomorrow we have another couple hours. Professor Amelia will work with you on some, social addictions first, and then I go on
using my phone right now.
Yeah, that's what I have to do. Like the first day we came back, like last semester or something.
It was like the
I feel
test day, right?
it was when everyone's like emails got like all hacked or something, and like no one could get in. Yeah. I feel like they're on Blackboard.
She said they're on Blackboard.
No, I don't know if they are. I feel like they might be.
Okay.
I don't know.
Grading rubrics
Like they should have that on there, no?
I know. This is the worst one. The process recording is the absolute worst.
I literally don't even see it on here. I just see like the clue and stuff.
I didn't see it in there either. That's
Yeah,
why I was
that's
confused.
weird.
I'm like, is it graded?
Clinical. That's so weird. Sorry, that's a good thing too. That's weird that's not on there. It's not. It's not even under like clinical either. So I think it was one time. You would think that would be something important.
I know.
It's so
Well,
weird.
like she said, the clue. I didn't even notice the clue paperwork isn't there. That girl.
Oh yeah.
Then when I looked, I was like, oh yeah, it's not anywhere.
Yeah, that would have been good if it wasn't there. Yeah.
Alright guys, we're gonna get going just because there's so much information, okay? And I wanna make sure I can answer all your questions, those good things. Now, I already said it once, but I'm gonna say it again. You guys know I like to repeat myself. The goal today is to get through the MDD PowerPoint and case study, which is 50 slides, right? We can do it, right? Yeah. We can do it, we can do it.
I believe in you.
I believe in you too. I believe in you. That's more important, right? And also, I want to get through. I would like to get through bipolar disorder as well. It's part of mood and affect. I'd like to do that. Okay. If we don't, it's not the end of the world because we have time on Tuesday after the skills and dosage calculations. So it's not the end of the world. My goal is to get you out of here in a reasonable amount of time. But that PowerPoint is a little bit less, and I don't want to be rushing MDD. It's a huge concept, huge concept. It's the #1 reason people are admitted to psychiatric hospitals. Okay? And its side effects, or its not side effects, its symptoms are also indicative, make people have physical characteristics, difficulty with physical symptoms as well. So it's a big topic. That being said, the mood and affect with bipolar disorder is considered 4 hours, right? So how many questions do you think are going to be on the exam? Around 20? 12. No, I can't, no. Around 12, roughly around 12. MDD being a big, like 4 or 5 maybe, but not MDD. Bipolar disorder being a good number because it's pretty big category. Okay? All right. Any questions about that? On here is your reading. It is extensive as well, 1909, 1942 for MDD, and then the suicide is 156 to 165. Adams, we want to take a look at Adams as well. A lot of the medications we've already talked about. In what class? Do you remember? You guys did look at your PowerPoints, right?
Yeah.
And anxiety, right? So we use a lot of these, depression, you're going to hear me say that a number of times, depression and anxiety are married. So that's why the medications are good for, work well for both. Okay? So our objectives, we want to take a look at the pathophys, same stuff, pathophys, etiology, risk factors, clinical manifestations, according to the DSM-5, because the DSM-5 is the gold standard, right? That's how they diagnose. We're going to look at some diagnostic tests, some interventions, which include collaboration with interprofessionals, medication management, and we're going to review MDD across the lifespan. Here's your concept map. It's a nice visual that let you see how things are interrelated, the sub-concepts, the interrelated concepts, outcomes, optimal conditions in relationship to mood and affect. So you have this already. This is a review for you, okay? You have this in this particular slide might even look pretty familiar. It's a review. You did this in 125 with Professor Bish. We want to take a look at it, okay? So what are emotions? Tell me without looking at it, what are emotions?
Sad.
Yeah. What's another word for emotions? Feelings, right? In response to some stimuli. How about mood? What's your mood all about?
The general feeling that you have over a longer period of
Right,
time.
it comes over a longer period of time, right? And then your affect is what?
The way you present.
The way you present, absolutely. It's verbal and nonverbal reaction, okay? Can be in relationship to, it's unconscious, all right? And it can be either good or bad. So this is a lot of words, right? What do you want to know from this? What do you want to know about this?
The big system.
Yeah. Depression is, again, the number one reason for admission to the hospital. 18.8 million per year are related to MDD. It's thought to be, these are theories, due to changes in the limbic system, neurotransmitter changes, but dopamine, acetylcholine, and GABA. But mostly the neurotransmitters we're looking at are serotonin and norepinephrine. Can be related to environment. How does depression relate to environment? How do you think? Let's talk about COVID and isolation. How does depression relate to environment?
You're isolated, you don't have anyone to talk to, you're alone.
Correct, and isolation is not a good thing, right? Not a good thing for people, so it could affect your mood and affect. Well, how else do you think?
When you break your regular routine.
You break your regular routine. How else?
If you're in an abusive environment.
Abusive environment, absolutely, right? Abusive, yeah, you want to, like, those are linked to depression. And you want to take a look at, when you're thinking about those type of things, what is that called? What is that called? And what kind of therapy do we need? What kind of abusive relationships? Some type of abuse, what is that called? Trauma, right? So you want to be mindful with MDD of trauma-informed care. You want to be mindful of trauma-informed care for all of the mental illnesses, all the diagnoses, but for MDD you want to be mindful of trauma-informed care, okay? You won't see that question again, I promise you, but you want to be mindful, okay?
Professor, trauma and what?
Trauma-informed care. We talked about it in the anxiety class. Okay. I'm not guaranteeing you won't see a question on trauma-informed care, but you won't see that question. Okay. So what's normal mood and affect? It's really on a continuum, right? It runs from depression to mania. Everyone experiences the fluctuations in mood and affect. Standard of acceptable behaviors do vary, so it's difficult to really assess mood and affect. And again, it's on that continuum. You want to describe the characteristics of their behaviors when you are assessing mood and affect. So you want to make sure they're appropriate. You want to make sure you're looking at the range. You know, are they going on the range from depression to mania and quickly? You want to look at those kind of things. You want to make sure it's congruent with the event. And I always say, like, if the coffee maker is not working, I'm not gonna, like, I love coffee, but I'm not gonna be screaming my head off, right? gonna be finding a way to get the coffee maker working, right? That's congruent with the event. You need to manage, you need to make sure that the patient is managing themselves that way, okay? Questions? So theories of depression, they think it's a relationship to circadian rhythms, changing your 24-hour cycle, day and night cycle. The seasonal affective disorder is also under circadian rhythms. You know, is there increased sleeping and eating in the wintertime? Hormonal effects. What hormones do you think play a role in depression? Cortisol, absolutely. Higher levels of cortisol, right? And what else? Estrogen, absolutely. That's why women have a higher rate, they're thinking, right, based on these theories, women have a higher rate of depression. With decreased levels of estrogen, there's increased levels of depression. And then you're primarily looking in the 40 to 59 age group, right? What's happening 40 to 59 usually? Yeah, so there's a 12.3 increase at that time, so you want to be mindful of that. Interpersonal theory, relationships challenges cause grief and anger. That's what the theory is. Cognitive theory is we are what we think. That makes you think about how cognitive behavioral therapy is effective for depression, right? Sociocultural theory. Stressors play a role in depression. What kind of stressors play a role in as far as depression?
Money.
Money is a big one, yeah, loss of a job, what else?
Loss of a loved one.
Loss of a loved one, any kind of stressor that can come along, really, if you think about it. But those are the big ones, right? And abuse. You want to think about, you know, someone who has experienced abuse, really, because there's a higher rate of depression in people who have been abused as a child or as an adult, okay? So what is it? It's characterized by change in one's emotional state and functioning consistently over a 14-day period or 2 weeks. It's the most important factor is that the patient has a depressed mood. The onset is gradual and often accompanied with anxiety. Again, those two are married. Significant distress or impairment of functioning, feelings of despair, hopelessness, guilt, loss of self-esteem, loss of pleasure in activities, unusual activities. What's that called? Right. Feelings of worthlessness, substantial weight gain or loss, visual psychomotor retardation or agitation, aches and pains, excessive sleep or loss of sleep, and recurrent thoughts of suicide or death. We're going to get into suicide much more as we go forward. Combined with alcohol, substance use disorder, or bipolar personality disorder, it's much more difficult to treat because you have dual diagnoses, right? So you're dealing with both of them. Alcohol or substance use disorder are often the comorbidities. Why do you think? They're self-medicating, absolutely. They commonly turn to substances. What's that? It does affect the neurotransmitters as well. So then you, again, that's where you're thinking about the dual diagnoses playing a role, okay? We always rule out a medical reason. Why are you ruling out the medical reason right off the bat for any psychiatric illness? Why do you think?
Because you could treat it beforehand.
What's that? Say it again. Depression can be a complication of the disease process, absolutely. Why else?
The side effects of medications.
Can be in relation to the side effects from medications, yeah. Why else? Why is the main reason? What kind of symptoms are you experiencing with depression sometimes? Pain, right? Chest pain, even chest pain with anxiety, we talk about chest pain, right? But anxiety and depression are married, right? So you want to rule that out before you even get into thinking about, that's one of the DSM-5 rule outs, is to make sure you're ruling out other causative factors. Make sense? So again, in your assessment, you're looking at feelings of sadness or despair, the sleep disturbances, the anhedonia, the psychomotor retardation, the somatic symptoms like headache, GI stuff, chest pain as well. Rates are as high as 50% in post-conflict countries. And this goes back to the trauma, but it is a trauma. You're absolutely right, but it also goes back to your environment, right? Right. So what kind of things do you think in this day and age increase the rate of COVID?
That's Thursday's class.
No, it's not Thursday's class. Well, what other kind of things? COVID isolation, what else? In this day and age? Crime, war, right, in their environment. Inflation is really tough for people these days, right? I wish I had chickens, you know? Right? No, seriously. Huh? He's gonna get a nurse burnout. You're in burnout. Thank you, Nicole. Burnout in the nursing industry, in the healthcare industry. Okay? I've been experiencing a lot of it with taking care of my grandmother, as well as doing everything else, right? Because we're the family members, you're the nurse, you're the one who has to do everything, right? So nurse burnout, thank you for bringing that up, because I wasn't even going to address that. That's very important. You guys take care of yourselves. I'm not kidding. You need to take care of yourselves. I know this is a busy time for you, but you take care of yourselves. What's an hour a day? I mean, I know schedules are busy. My schedule's just like, all of our schedules are busy, right? But you need to take care of yourselves. Thank you, Nicole. What else? Anything else going on right now and has been going on? Yeah.
Well, it's probably not what you're alluding to, but social media is where it all, I mean, with COVID.
Social media is yeah, they say it is a leading, oh yeah, right? And Professor Mobilio is going to talk to you about that tomorrow, as far as addiction and stuff. Social media as well. Anything else? How about the political climate? Right? Political climate in the United States, absolutely, and what's going on as far as that, as that goes. I'm not going to get into that with you, but you want to be mindful of it. I literally had fights with my family members, and people have unfriended me because, I'm like, we're at this point, what is that, right? You need to, everybody has an opinion one way or the other, right? But anyway, you want to be mindful also that different cultures handle depression differently, right? Your assessment of them should be different. How so? Can you think of any cultures that are different? Yeah.
I think that there's certain ones that are more expressive. I think in Spanish culture they tend to express more.
Yeah, Latino, yep. Spanish culture will express themselves more. So what else?
I think in terms of yes, that's what I was going to say. In terms of depression, is the opposite of that. Right. They don't know.
Because why? Why Latino and African Americans? Why do they have depression more? Because there's a stigma associated with it, right?
Is there distrust of healthcare as well?
Distrust of healthcare as well. So you want to be mindful of those things when it comes to culture, because it's not necessarily right. It's not, everything's not the same as what you're saying. Okay. The Chinese culture, and I know you have this on your notes, but they're very high, they're high achievers, right? So they will, that's a stereotype, but it is a good stereotype, honestly. For the most part, the Chinese culture, they're go-getters. They're okay? They are. I'm not saying anything. Yeah, well, I should have said Asian. Yeah, all of them, okay? But you want it, so they really don't show, and they're not a culture that shows themselves as far as mental illness, right? So you're going to be looking at somatic symptoms. Those somatic symptoms you're going to rule out, right? But you'll look at those somatic symptoms instead for that culture, okay? Questions? Comments? So this is just the DSM-5 criteria, copied directly from the DSM-5, okay? You want to have greater or equal to 5 symptoms during the same 2-week period. You want to rule out the medical condition. Depression most of the day. Symptoms may vary based on lifespan considerations and are subjective. You do have that lack of interest in activities and social and day-to-day stuff, okay? There's feelings of worthlessness, or excessive, inappropriate guilt nearly every day. Guilt may be delusional. What's delusional? Not real, right? So, not merely self-reproach or be guilty about being sick. Decreased concentration nearly every day. Maybe indecisiveness, may be subjective or observed by others. Thoughts of death or suicide, recurrent thoughts of death or suicide, okay? They may have suicidal ideations. What is it? This is review for you guys, so that's why, I figured I'd ask. What's a suicidal ideation?
Killing yourself.
Well, they're continuing, like, they're constant thoughts of killing yourself, right? You're always thinking, like, or, you express it,
You
okay?
can almost be like obsessed with it, constantly.
In a
thinking about
sense,
it,
yeah, you're thinking about it quite a lot. You ruminate over it, yep, yep. Really deep in thought about it, obsessive in a sense. There may be a specific plan or suicide attempt. What if you have a specific plan or suicide attempt, what are you doing? We're gonna get into it more, but what are you doing immediately?
1-to-1.
988, right? You're not leaving them alone, and you're getting some help. Absolutely. We'll get into it. Weight loss is a part of it as well. When you're not dieting, but you lose a significant amount of weight, or gain, or decrease or increase in appetite nearly every day. In children, it may be a failure to thrive. Insomnia or hypersomnia every single day. Psychomotor agitation or retardation nearly every day, and visible by others. Not merely subjective, like being restless or slow. Okay? Symptoms are clinically significant and their social impairment, occupational impairment, there's just, you're not functioning, you're not doing your day-to-day activities. Episodes are not attributed to any physiological cause or medical condition or substance use. Episodes not explained by any other mental health illness, and that's always a rule out for as a diagnostic on the DSM-5. You don't have schizoaffective disorder, you don't have any of the other disorders. You may have anxiety as a comorbidity, but you don't have any of the other disorders. And you don't have a history of manic or hypomanic episodes. That's what? Bipolar, absolutely. And this is all online, guys. I just, that's my source there. So what are some risk factors? Family history. You're 3 times greater to have a chance of MDD if you have a first-degree relative with depression or other mental illness. We already talked about females 40 to 59 with an increased rate of depression. History of trauma, and when we talked about trauma-informed care. Poverty is also a stressor. Why is poverty a stressor for depression? What's that? You don't have the basics day to day. That is a stressor. That is a huge stressor. Okay? So we want to keep that in mind. Lower level of education, unemployment, no social support, and culture. And we already talked about it as well. We talked about African American and Latinos with lack of community support. That group will go to the family prior to going to somebody who's in the medical field because they trust their family members. And then we also talked about the Chinese culture, more apt to report, or Asian culture, more apt to report somatic or physical symptoms versus Canadian and European cultures. So MDD, there's no definitive prevention. Genetic and biological factors cannot be modified. But there are some approaches to use to controlling it. Healthy diet, what are we looking at for a healthy diet? More fruits and vegetables, what else? What's a healthy diet in general? Because that's basically what I'm asking you.
Low fat, low sugar.
Low fat, low saturated fat, low refined sugar, right? Not a lot of junk food. Research states that omega-3s, fatty acids, vitamin D, selenium, calcium may be preventative, okay? So you're looking for those nutrients as well. Regular exercise, what does that do for depression? Releases what? Endorphin, serotonin as well, right? So that is very helpful. Avoiding smoking, and you know why, right? Why? It's bad for you in general, but what? The nicotine can increase the what? Anxiety symptoms as well, which, and again, they are related to each other. Stress management education. What do you want to tell your patients for as far as stress management education? How are you guys going to manage your stress now that we talked about nurse burnout? Deep breathing, take the time, put the time out, and put the time in your calendar. What else? What are some that we use for people who are actually admitted as well, right? What else? Medication, yeah, that's self-care. It is if you have depression, absolutely. What else though? Complementary stuff. Come on.
Guided imagery.
Guided imagery. What else?
Meditation, yoga.
Meditation, yoga, all of those things, right? And that might not be your thing. If exercise is your thing, we'll exercise, right? But you want to find out what it is the patient's, what the patient's interested in, what's going to help them. Okay, you want to assess them for that. Trauma-informed care we talked a bit about. You want to be mindful of stressors. What other groups are helped with trauma-informed care? There's a lot of groups out there, right? So what other kind of groups? The men-to-men group, all those kind of, if they're dealing with other issues, you want to be mindful of that. So you want to ask those questions. What is your trauma? Did you have prostate cancer? We're gonna hook you up with the men-to-men's group, all right? You always want to think about that when you're dealing with a patient who has a history of depression and mental illness. Cognitive behavior therapy or dialectic theory, talk therapy. You are what you think. That's basically CBT. And the goal of CBT is to present reality, right? Have the patient come to the reality, right? A more realistic point of view. Physical examination, you want a complete set of vital signs, including pain. You want to make sure you get a neuro assessment. You want to get a baseline for weight because that's one of the symptoms. You want to look at sleep, nutrition, activity, elimination patterns. The thorough physical exam is to rule out other causes and to identify any comorbid medical issues. So no, there's no laboratory test to diagnose MDD. You want that thorough workup because symptoms of MDD or mood disorder can mimic a medical problem. So possible tests you're looking at are thyroid function test or any endocrine test in general. They may have hypothyroidism, there may be sluggish or fatigue in relationship to the hypothyroidism, so you want to get thyroid function test. An electrolyte panel, we're going to talk more about this tomorrow with the electrolytes, but sometimes if you have low magnesium, low calcium, low phosphorus, well, how are you feeling? You're tired, you're fatigued, right? You have decreased motor function. So you want to get a full electrolyte panel. You want to get a urinalysis. Why? Rule out an infection and look at how the kidneys are functioning. Toxicology is self-explanatory. You want to see if there's drug and alcohol use as a comorbidity. Why else? What else do you want to check as far if you see a high toxicology report, or in general, you want to take a look at the liver enzymes. Is there liver damage? You want to do that as well because a lot of the antidepressants are metabolized in the liver, so you want to make sure that their liver is functioning. Pregnancy test. The antidepressants may affect fetal development. And some of the signs and symptoms of pregnancies are also fatigue, right? You're feeling fatigue a lot when you're pregnant, so you want to do it for both of those reasons. The antidepressants can cause fetal complications. So you want to make sure that you're getting, making sure that you're checking to see if the patient's pregnant or not. God bless you. Persistent depressive disorder or dysthymia, or dysthymic disorder. This is the DSM-5 criteria. It's chronic depression most days, for at least 2 years, 1 year for children and adolescents. No more than 2 months are symptom-free during that time frame. Symptoms are less severe than MDD. But the degree of impact can affect the individual. Often occurs in childhood, adolescence, and early adulthood. Boys and girls are equal on that matter when you're in that lifespan, and 2 or 3 times greater in women than men. In childhood, the reason for poorer outcomes is commonly a comorbidity. So they may have conduct disorder in childhood, and in adults, anxiety disorder as well. So in relationship to dysthymic disorder. Okay. Suicide. Suicide attempt is when you do actually have the action, but it's not fatal, but the attempt was to cause death. Suicidal ideation, which we already spoke about, was constantly considering, thinking, or planning suicide. Influencing factors are genetics and neurobiology, interpersonal factors, comorbid disorders, and social factors, same as depression. Those are the same ones, right? Risk factors: isolation, recent unemployment, recent loss of a significant relationship, feelings of failure, hopelessness. You want to assess if they have means, right? So do they have a means to carry out suicide, guns, whatever. Sometimes it's the simplest things that you wouldn't think that they would be able to do. I mean, there's quite a few stories out there about people being able to complete suicide and being on suicide watch, those kind of things. So it really, really needs to be assessed for their means, okay? Especially if they should never be unsupervised, but if they're a low risk, sometimes that will happen. If you're supervised by family members, so you really need to do a very, very good assessment of that, okay? If they have cluster A personality disorder, Professor Mokulis can talk to you about that. And if they've had I think I've already said this, but if they have had an attempt in the past, there's a higher likelihood. If they have the comorbidities like bipolar in the manic phase, that's when you're really looking at, they're 15 to 20 times more likely to commit suicide to completion. And when it's suicide to completion, that's when they die. Basically, that's a big thing. Yes?
Just before we get too far past this meeting, can you just explain to me, if you're assessing a patient, how do you know if it's MDD or the dyspnea?
It's a longer period of time and the symptoms are less.
For dyspnea they have.
Correct.
Okay.
Correct. They could be I think I said greater than 2 years.
Okay.
Right? And it could be episodic as well, like with depression, you might have some periods of remission, but they're not as much as MDD. Okay. So I didn't ask if you had any questions after that one, so I'm glad you asked. Somebody else have a question? That's gonna come, yeah. That comes in the bipolar slide as well. He's showing you he's talking about how it is. This is like this, right? This is the line for persistent, right? Depression can go a little bit off, right? That's a good way to explain it. Ryan, you should tell everybody. No, that's really, but I mean, that's better than, that's a good way to explain it, and I like visuals, and you will be seeing that in the bipolar one to compare them, but that's a very good way to explain it. What's that?
There's a good graphic in the technical.
Good. Yeah, in Pearson?
Yes.
Okay, excellent. Questions about suicide? You guys reviewed this in your first level? On first level or not? Yeah? That's to this extent. That's really what this semester is. We get into it, into these quite a bit more, but you do have a little baseline for it, so I'm glad. So the clinical manifestations of suicide. I am going to post a next-gen case study for you on suicide in Blackboard, I promise. I just haven't, I'm trying to figure it out on the site. So, and if you don't see it, you can hold me accountable because those are my plans, all right? Because I do want you looking more at those next-gen, we're close. So we really have to get a plan and do this a lot more, okay? So please get to me and let me know if I forget about it or whatever. Okay, I probably won't, but I do. I'm accountable. Okay, so let's talk about behaviors and then how about a break? I think that's a good idea. Okay. So clinical manifestations, behaviors. There's an increased rate of suicide to completion in the lifespan of during adolescence, right? Because they are usually, for everybody who is thinking about suicide, but mostly adolescent, you have impulsivity, aggression, might have a negative affect. You're looking for signs such as, or people saying, I'm not going to last much longer, if they're doing things like getting possessions away, right? If they buy a gun rope or anything, and there's a lot of pills at home, anything along those lines, you want to be mindful of that because the behavior those behaviors can lead to completion, just suicide to completion. Cognition tends to be rigid when patients are thinking about suicide. Overgeneralize, predict negative outcomes. There is that, and then we talked about it in the previous slide, there is often social isolation, loss of a loved one, participation in social events stop. You're looking for these kind of events. And with COVID again, there was a bump in suicide rates, right? There was a bump in suicide attempts. So you want to be mindful of that isolation factor. Cultures, highest rate of MDD suicides are in American Indians and Alaskan Natives, followed by non-Hispanic whites, and then African Americans are the second lowest, and the lowest is really Hispanic. So you want to keep thinking about that cultural aspect of everything, but this as well.
Who's after whites?
African Americans.
Then Latinos?
I don't have Latinos in here. I know, I left you guys out. What? Hispanic, yeah, it's part of Hispanic stuff. It's part of the Hispanic. What? Because of the depression leads to substance use disorder, I believe. Yeah, but substance use, usually they're trying to kill the pain, and that's why they use substances. From what I've seen, I have to research it though to give you a definite answer. No, it's a good question. It's a good question. But from what I've seen, people use substances and alcohol in order to kill the pain.
talking about somatic and Chinese culture.
Yeah.
Are they more likely or less likely to present with somatics and more?
More
More likely.
likely, yeah.
Okay, and I have another question. Didn't I read that their culture is more accepting of suicide?
Yes.
So where do they fit in this,
Again, I'd have to research that, but I would think higher up because they are.
can be up there with probably.
Yep. Yeah. Yeah.
Okay, thank you.
And it may be in your book, I just omitted it for some reason. But, you know, again, if you post stuff to discussion on here, you can say what you want about me, but I'm pretty good about answering those questions, okay? So please don't forget, because you're asking it, other people are thinking it, over here was, these guys are thinking, even though I spoke to them Hispanic in general, they're thinking about Latinos. That's easy to research. Right. Okay, so please put them up in discussion board. Any other questions? Yes?
Can you elaborate on what collaboration means?
Yeah, I can. I'm not gonna go back. With suicide attempts, but depression in general, but suicide attempts primarily, there's a huge collaboration. You need everybody on the team because once someone attempts, the likelihood of trying to attempt or, going down that road is very high. So you want to make sure the psychiatrist, everybody on the team, the nurse, they have their meetings, like they collaborate, just like you see in the hospital. They collaborate, they're all together, everybody, right?
Yeah.
Everyone on the team, the techs, when we used to go to the psych units, right? You would see this collaboration, it's really important. You're on the team, you're talking about what is going on, okay? I was in debriefing on an attempt once, and everybody and their brother was there, including the family afterwards. Like there was a separate one for the family members as well. And that's the way it should be, because what's the end game here? That is the end game, it's nothing, right? You're not coming back from that. Yes?
So if, speaking on one-to-one, and say you have a patient that came in for reasons of self-harm, but they didn't say that they actually wanted to kill themselves, at what point do you place them on a one-to-one? They at least state that they are actively making
The psychiatry, that is not for us to determine, that's determined by the doc. But you're gonna call absolutely if there was some self-harm. Yeah, you're gonna call, we're gonna go through the Columbia Suicide Scale and we're gonna talk a little bit more about that. But honestly, if there's any indicator for a suicide, like an attempt or anything, or any indicator that they're hurting them, because some of the, especially in adolescents, right? Adolescents don't understand, like, again, we're talking about the time period, they don't understand that, cutting, right? Cutting I'm just giving you an example. Cutting their arm near their major, right, artery can't cause death. They don't get that, right? A lot of times when adolescents cut, it's superficial, but still, they don't understand how risky that is. All of their risk behaviors for adolescent time frame, right? Driving, drinking, driving, all those kind of things. Adolescents don't understand that. So you really want to be on the lookout, okay? Did I answer your question? Yeah. Yes, men are more likely to commit suicide. I don't have the actual age than women, but women are more likely to attempt.
So men are more likely to
suicide to completion, men are more likely to have, and that's the term, suicide to completion. Women are more likely to attempt, but women use different means, right? Women will use pills, women will use different, men, it's usually a gun or a knife or hanging, whatever, right? So that's really and that's just men and women to like gender differences in general, and that's why that happens. Okay? Any other questions before we break? I don't know why I'm looking at you, Ryan. I don't know why. Do you have a question? All right, let's take a look. We do 10 minutes. 10?
Honestly, my daughter doesn't know she wants to go to college, so that's kind of like why I'm kind of holding back. If I go down south, I'll probably go somewhere that has a lot of like sign-on bonuses, just to help with the move and everything. I like the Carolinas. She wants Florida. Yeah, all of our friends go there. That's the problem. So it has to be, you know, if I'm happy, then it's kind of worth, you know, my family's happiness is worth the sacrifice of the money. But I could always do like travel nursing. I could always come up here a few months. You know what I'm saying? Bust out a couple weekends or whatever. Go back. You know? So it is what it is. Right now, I don't know if I want to stay in the nursing home because, like, I've been a supervisor lately as long as the RN in the building. I thought it was going to be helpful, but like, the place is so close that like, something like tells me that that's not true, and then I feel like I was serving that day, I should have done that, but I'm okay. You know, so it's kind of like I feel guilty, but then I got the patient down, but then like my partner was not my partner, so it's like a mixed feeling. Yeah, and that's why I'm kind of like, how sick is it that they feel like they want to do that? And two, you know, like, I know, but usually there's like a lot of work that I can do, but this day was kind of like, and one was like all the time, even with like all the older
I was going back to prison. I really
So what kind? What do you want to do with it? I like that idea because I would want to be a surgeon, but it's just like we have to have more stuff like that. So you did all. So what do you want for I didn't know this, but I'm gonna look at it. I'm gonna look at it tonight. Yeah, I'm gonna look at it tonight. I get out. Tonight I'm just gonna go and cook some. I'm gonna try to like, I got you. So I've been, yesterday I made 2 different kind of chicken proteins and stuff. Well, I made some 2 proteins. Where you at? St. Mary's 3. She can't be with the first day. That would be Thursday night. So, and then which there is a early morning. Actually, you never get it. Yeah, you never get like until like the when we did our project, she was super stoked for the project. Well, other than that, and I think she gets like this honestly, yo, she has a flat accent. Well, anyway, I mean, we go use the bathroom.
How about that? All right, what's your name? Your critical thinker? Thank you. All right, guys. So there are different scales in order to assess suicide, or suicide assessment scales. One of them is a 5-step evaluation triage, or SAT. It is used, the Columbia Suicide Severity Scale is used with it, and it assesses the risk factors, and then determines what we're going to do. So is there a suicide risk or suicide ideation? Assess protective factors. What are the protective factors? Social support, yeah, trusting relationships, okay? It asks about thoughts, plans, and behaviors regarding suicide, and it assigns risk levels as low, moderate, and high, based on the 3 assessments, based on the first 3 questions and the Columbia Suicide Severity Scale. So when assessing risk factors, if they are low risk, what do you think? Once they use this Columbia Suicide Severity Scale and they're low risk, what do you think is your plan of care? Where will they be treated, do you think? Low risk? Usually outpatient, yep. Can be home. What if they're a higher risk, like increased or moderate? Moderate could be day treatment, as long as there's someone at home that's able to assess correctly. But if they're high risk, they're absolutely going to be hospitalized with continued evaluation before you increase their privileges, or they are able, then eventually they'll be able to be discharged. On your assessment, you want to get a full family history. If a relative has attempted suicide in the past, there's a higher risk. Self-injury behavior such as cutting, bruising, burning, pulling a hair, extreme nail biting, all needs to be assessed. It needs to be assessed according to where the patient is on the lifespan scale. Again, with adolescents, their thought process is not necessarily, that they're doing it to relieve pain. They're not doing it usually as a suicide attempt, but sometimes, that's some of their behaviors. That's how it happens.
Did you say nail biting?
Severe nail biting is one of them as well.
Severe nail biting.
Yeah.
Okay.
Yeah. You're okay, Ryan.
Oh, thank God.
You bite your nails, you're okay. No, severe. Some people literally, you can see some pretty bad cases of it. Where it's, the cuticles, the whole biting. Right? Awesome. You want to develop a safety plan or contract in agreement with the team, and you're never leaving them alone when they're at high risk, ever. And their own precautions, as you discussed earlier. The Columbia Suicide Severity Scale. This is the gold standard for assessment. You guys can go on and get yourself trained, and it doesn't take a whole heck of a lot of time. You just look at the scale, and it's a really good thing to put in with your packet. So when you're, when you have some free time, but you want it, you would want to go ahead and do this. And if you go, I don't think this will go because I didn't plan for it, but let's see. Oh, it went. If you go on to there, it gives you everything that you need for the online training, okay? You'll be able to add it to your resume. It looks good that you went ahead and did this. Suicide's a big issue, a big concern, okay? Yep, I did that to my PowerPoint.
Don't worry, you never left.
I never, oh, here it is.
Yeah.
Because you need the power.
Probably take a couple hours.
Oh, whatever. You guys know I'm a little technical late. I have some technical issues, right? Here. Beautiful. Okay. right, you guys are okay, good. Okay, so the suicide prevention hotline is here. There is also a copy of the Columbia Suicide Severity Scale, a part of it on there. When you go in the training, you can get the whole thing. But on the scale, you're checking, again, you're checking as far as risk.
I think your slides are up.
I'm sorry.
You have to go back to the original.
Go back to the original one?
Yep.
Yeah, 1 second. I don't see it now.
We can see your screen now.
You don't want that. Open it again. Sorry, guys. Thank you. There we go. Thank you. Thanks for the assist. So the suicide prevention lifeline, that's the actual number for it, like if you're gonna dial the phone, but they determined, like 911, 911 is much easier, right? And, you know, if you're thinking about, when I talk to somebody about an attempt for suicide, you're not gonna wanna be looking for this 1-800 number, right? So now the number is, you wanna dial 988 directly, and you wanna use that as a reference for your patients. Okay? Here's a picture of the suicide severity scale again, and you will see it on, when you go into get your training as far as Columbia suicide severity scale. Okay? But it asks questions, it asks a bunch of questions about intent and all that. And here they are. You know, you want to ask each of these questions on the scale, and again, you can see the actual scale when you go in, but you know, have you wished to be dead or wish to go to sleep and not wake up? Have you actually had any thoughts? If you answer yes to 1 and 2, it's kind of like, if you answer yes to 1 and 2, then you go to 3. If you answer no, then you like, that it's progressive. Does that make sense? What's that?
Because people say that, oh, you say that if you want to go to sleep and not wake up, that it's not a plan to kill yourself.
No, but then if you say yes to that, then you want to assess plan. Make sense? Any questions? It's just progressive. All right. And then interventions, they do also have interventions in relationship to what yes or no questions. So we talked about the interventions of if it's you know, low risk or high risk, what you're doing. Okay? Meds. We love meds. We love meds. We're nurses, aren't we? You hate meds. I know you hate meds. That's why they're tough, right? All right. Listen, here's the deal. If you have a question, and we're really trying to do this now as far as exam questions, right? If there's a question on the medications, you're going to see the category, criteria, the category, whatever category it's under, right? You'll definitely see that. And if you see, and you may also even see the prototype. I did put like a little pill next to the prototypes that are in your book. All right, so those are the ones you're looking for, right? But they're categorized. They all kind of usually have the same adverse effects. So you want to study them as far as categorized, as far as categories. Make sense? So yes.
You're on the test instead of being tell us the category.
I am, and I think that's what Next Gen does, and so that's what we're gearing it towards. Okay? So you can study the category instead of the actual pills. But you should, like if you were in practice, you would be seeing these meds, right? So you should have some kind of idea, like, you know, what I'm not going to hold you to is this one is effects for atypical antidepressant, right? We can't hold you because NCLEX is not holding. That's the Next Gen is not, like the Next Gen test is not doing that. So why would we have you memorize meds? Yes.
Is fluoxamine the same as fluoxetine?
Yes.
That's the same thing.
Yes.
Because I thought Prozac was throughout the T, with the T.
I think you're right.
Oh, it's a misspelling.
That's okay. I just wanted to make sure I had the.
No, and do me a favor, please, let me write that down right now.
Yeah.
But if I don't correct it, let me know, okay? Hey, you guys, when you pick up, I forgot, I was gonna bring prizes here. But I forgot about it. Okay, so I'm, in my defense, I'm really used to the generic, not the generic names, the other names. Seeing them all the time, but that was a good pickup, thank you so much. I'll make sure I put it down. So we're looking at what, for the same, we're looking at the same type of medications as with anxiety, right? You saw all of these in anxiety, right? And again, they're married, okay? So so the SSRIs, you can see the names there, Zoloft, Celexa, Prozac. Atypical antidepressants, you're looking at Effexor. TCAs are Topranil and Elavil, and the MAOIs, you're looking at Nardil as your, right? Let's look at the SSRIs, and you guys know this information, so I'm going to ask you, right? Okay. Why do we use the SSRIs? Primarily first group. There's less side effects to them. How long does it take the SSRIs to get into the system?
6 weeks, but max effect is like 2 months.
Correct. Say it again. A few weeks.
But the max effect
is a couple of months. Okay. What's that? Yeah, usually, and sometimes people are on them longer. Yeah. The adverse effects you can read: dry mouth, nausea, headaches, nervousness, fatigue, anxiety, insomnia. Sexual dysfunction in 70% of men and women. So that's the primary reason people stop taking the SSRIs, because of their sexual dysfunction. So you need some counsel, you need to, as a nurse, you need to figure out other, there's other medications that can be taken, okay? And you need other things that can be done as far as supporting them with the sexual dysfunction, okay? It needs to be talked about. Sometimes, like a new nurse, I remember when I was a new nurse, when you'd ask about sexuality, and it was like, oh, I was young. Sometimes it's like, it gets kind of, it could be uncomfortable, especially if it's like a male, female, whatever. But it needs to be discussed, because this is a big issue. When they stop taking their meds, severe depression, then we could be looking at maybe suicide attempt or something. So you don't want to play around. Serotonin syndrome. What's that? Yeah, high level of serotonin. What kind of symptoms are you looking at? Nausea and vomiting, increased temp, increased heart rate, shivering. Patient might be clumsy. There's muscle spasms and sweating. So any indicator of any signs or symptoms of these, a patient's on an SSRI, you want to be doing you want to make sure psychiatrist is doing some med assessment, right? Okay. What about Stevens-Johnson syndrome? What's that? Yeah, it's really bad, right? You start with a bad the skin and mucous membranes are affected. It's usually painful. If there's a rash, it spreads. You wind up having some blisters. You can have some flu-like symptoms. It takes a very long time to recover from this. So if you see anything right off the bat, you want to let somebody know about it. You don't want to be playing around, okay?
It's considered rare though, or no?
They are rare. Yeah, it's not, the percentages aren't that high, but if you notice these things, and they're indicators, they can be an adverse effect of SSRIs.
Okay.
So you need to be mindful. Atypical antidepressants, which includes the SNRIs, are listed here. Cymbalta and Effexor are your prototypes. Adverse effects here, you're looking at
increased blood pressure and heart rate, right? That's a little different. And it could be a big problem. So what you want to do is to make sure that they don't use these as much in relationship to that, because you can run into some serious circulatory issues. So this is the second line usually where they're using. Tricyclic antidepressants, Topiramate being the prototype, and you're looking, what's different here? What's different as far as the adverse effects here? Hypotension, yeah, what else? Orthostatic hypotension, what else? Agranulocytosis is huge. You want to make sure you're mindful of that. Okay, so make sure you're checking your white counts. You don't want to play around in your granulocytes. Okay? The top relevant effects are used in the clinical areas, but again, you want to go with the least side effects first. Start with the SSRIs usually. I mean, we don't prescribe it. That's how usually just letting you know that's how it goes. Okay?
I just have a comment.
Yeah.
Effexor is on this list also.
What's that?
Effexor?
Is on there twice.
Well, I thought that was a SNRI.
I think it is, you're right. Yep. All right, let me fix that. I apologize. I'll fix that. Thank you. On the tricyclic antidepressants. Second one down, cross it up your side, please. Thank you. Thank God I'm doing the categories instead of the actual meds, right? Now you guys are pretty happy about that. That's nice. Did we do those already? All right, so we said agranulocytosis, bone marrow depression, seizures, heart block, myocardial infarction. Those are a little different, right? Angioedema of the face and tongue, generalized weakness. You don't want to play around with this. There's more symptoms. There's more adverse effects here. MAOIs last, usually. Yes.
So, quick question. In regards to like the exam, I know you're asking us to specifically look at the category of the medication. Can you give an example of what kind of question you might ask? Are you looking for us to like identify the medication for the correct category?
Yeah.
What are you looking for?
That's not fair. I'm going to tell you the medication and probably the category as well.
Oh, okay.
I want you to know the adverse. What do you think I want you to know? Really, the adverse effects,
Okay.
and why you would be using the SSRIs as opposed to the MAOIs, as opposed to like those kind of general things, because that's what next gen is going to be asking. We are really trying to get there.
Okay.
It's a process for us as well.
Yeah.
But that's a good question. I'm glad you asked.
Thank you.
So let's talk about the MAOIs. Nardil is your prototype. These are the last one used due to the many adverse effects. Suicidal ideation, serotonin syndrome, respiratory collapse, hypertensive crisis, and circulatory collapse. They're pretty severe, right? You can have a hypertensive crisis. I don't know how many times we say this to you, but we've seen it as an NCLEX question, so we keep going over it again, right? Hypertensive crisis in relationship to MAOIs and tyramine. What kind of foods? Let's go through them again. cheese, what else? Wine. Seafood, wines, yeah, what else? Especially the reds on the wine, right? Beer, yeasty stuff. You cannot take those because they have tyramine in them, right? What else? Salamis, processed meats, yeah. What else? Papaya, which is in meat tenderizers, so you want to be careful there. Raisins, bananas, avocados. I said papaya. Sour cream. Bologna, everything that you like. Pretty much, but just be mindful.
Yes, I can have sour cream on the bread.
I guess it's right?
No cheese, no
That's why emails, again, and I think stress it as far as NCLEX and we're just talking about it because if you're not taking an MAOI, you don't have to worry about those things, right? But you want to be worried about those things if you get to the point where you're on an MAOI. So it's the standout stuff that I want you to know, basically. And you're already on it because you found the effects here, so you're doing good. Okay? Okay, perfect. All right, so non-pharmacological therapies, electroconvulsive therapy, ECT, and transmagnetic stimulation, TMS, we're going to talk about in the next slides. Vagus nerve stimulation is a new thing. Usually a plant is imported in the chest, and then there's a transducer. It's used for seizures as well. The problem with vagus nerve stimulation, it's good for depression. The problem with it is that you worry about infection at the site and also difficulty swallowing afterwards when you stimulate the vagus nerve. There's a new non-invasive vagus nerve stimulation approach, which the Food and Drug Administration has authorized. That's the word I'm looking for, right? Approved. Thank you, Ryan. But I haven't seen, I haven't heard anything about it being used, but it is approved by the Food and Drug Administration. So that worry of infection, it takes it right out of there. Psychotherapy with medications, a combination of the two. Light therapy, especially for those also with seasonal affective disorder. And the complementary therapy, yoga, acupuncture, medication. Vitamin B, omega-3s, and fatty acids are all non-pharmacological therapies. Electroconvulsive therapy, still done, still very effective, but it usually is for, well, first of all, electric current is necessary, right, to reduce seizures. It's given 2 or 3 times a week for 3 to 4 weeks. Second line therapy for resistant NPD and bipolar disorder, right? Produces similar rates of remission with patients in these conditions. Effective in 90% and 80% of the people, so that's a good thing, right? Higher, response is higher in people who have depression, but also those psychotic characteristics. There's a relatively rapid response as we look above. And patients who are, bipolar patients can also have ECT. They don't necessarily turn into to become manic. They don't go into the manic phase if they have the ECT, so that's a nice thing, okay? Very useful. We use these for people who are severely suicidal and those with severe psychomotor retardation. So, beforehand, you want to make sure they do EEGs, EKGs, pulse oximetry, vital signs, all that kind of stuff. They may have some mild confusion afterwards, but it's transient, so you need to let your patient know that it is transient. It could be very concerning, being forgetful after you get some electroconvulsive therapy, okay? PrEP is like surgery. You want to make sure they have emptied their bladder, they remove if they have contacts in, there's a big gauge ID in place, they have a marked guard in place. For recovery, you want them in the lateral sideline position, okay? Why? Yeah, you don't want them to aspirate. It's to prevent aspiration. It can be done as an outpatient. I've seen it done. There's a pile of videos on. You've seen the patient before and afterwards. It's amazing. And there's a bunch of, if you Google it, there's a bunch of videos that you can look at as far as ECT. It's quite effective. You just want to be mindful if it's in an outpatient, they can't drive afterwards. ECT? It's deep brain stimulation. Yeah. ECT is primarily, they do it also for seizures, yes.
When you say second line, is that compared to that like after medication or compared to the other non-pharm strategies?
It's usually severe depression, is what I'm saying. It's the second line of treatment. Yeah, you try with medications, if it's persistent or dysthymic depression, usually that's what these guys are showing. And it's incredible the response. You see 80% up there, that's based right from your book, but the response is incredible. I saw it a few times even when I was in my bachelor's program, I saw it. It was like, I was like, wow, it works very well. But we don't go right to it, why? Why don't you go right to ECT? Why would you, if someone has, a milder case of depression, which is, depression is depression, to say mild and depression is kind of tough, but why?
It's invasive.
It's very invasive, you're making them have seizures, right? You need to have everything there, so they don't go right to it. It's those cases that are very difficult. Make sense? Repetitive transcranial magnetic stimulation. This is a newer, it's been around for a little bit, but it's a newer type of treatment, TMS. Magnetic field passes through the skull, causes the cerebral cortex cells to fire, and they target the certain areas. For depression, they target the left prefrontal cortex, and for mania, they target the right prefrontal cortex. It's rapid in action. There's fewer side effects than ECT. The benefits are fewer though, and there's shorter duration of, working. It works for a shorter duration. Most common side effect is discomfort at the treatment site, which is usually transient and goes away. And in a rare case, there can be an issue with seizures. So you want to be mindful of that. What's that? Seizures. So some lifespan considerations. Are we done? Oh, okay.
Can we interrupt 1 minute?
Yeah.
Since we already
I was like, I'm trying not to rush, but I'm like,
we're trying to figure out when your break was.
I already gave him a break. It was like 11, that's okay. I'm not going late.
Because my voice just isn't loud enough. Okay. Please, if you have your computer, if you don't have it with you today, come early tomorrow. I'm just going to share my experience. I went on with my personal computer and could not get onto the Wi-Fi. They did an update.
Yeah, I don't know why.
They did an update.
I think probably because I had to fix it like late last semester.
Yeah. So of course. So just settle yourselves, make sure you get that checked. Sign on to ATI on campus. For those that have your computer with you, do it today before you leave. So if you need to contact IT, do so. For those that don't have their computer here,
just
go a little early.
That's not the thing they find
on site here at Water Hall to troubleshoot some things.
Knowing my luck, it's fine now. It's gonna like die tomorrow. Yeah, during the time.
No, come to your room.
Do you know our room's posted
The
yet?
IT will just be kind of floating.
For like, I don't know. I assume it might be just the same as last semester. I don't know. That's what I'm assuming. I would love that.
No, it's not Jenny's. It's extra hall on the sixth floor.
The issues with Wi-Fi, correct?
Issues with Wi-Fi connecting to your computer. I mean, you need to know your passwords for ATI as well. Go ahead.
So students in a computer lab are using
The computer in the computer lab. Okay, and if you're in 125, you can use the computer in 125. So if you are scheduled in 352 or in 102, we're expecting you to bring your computer and utilize it. All right? If not, let me know if you don't have one. And then obviously, you want to start on time and have things go smoothly. 15 degrees out there.
Sorry, I interrupted. No, that's okay. I was actually upstairs when it needed to come. But she had the issue, and that's why she brought this forward. Take care of it today, if you can, please. Just make sure as soon as you're done here, try and let it be. Talk to IT if you have an issue with the internet on your computer, okay? Okay. All right, back, oh, I lost this. Now I know where it is. How's that? Good? Okay. All right, so let's go back to class, guys, okay? Take care of that today, though. All right, so lifespan considerations, children and adolescents. Toddlers may exhibit regressive behaviors like toileting, they may be bedwetting, doing those kind of things that they haven't done before, right? Preschoolers are can be self-destructive in their play, they can whine, they can be irritable, they can lack confidence and interest. School age, decreased academic performance, decreased physical activity, somatic complaints, boredom, low self-esteem, running away, talking to older kids, those kind of things. Adolescents, you're looking at decreased social contact, poor social school performance, not involved in typical activities. You want to be mindful of the adolescent time period and thinking about suicidal assessments. They are impulsive. Okay. Postpartum, you did this in your first year. Postpartum depression is in Pearson. It says it right there. It's not just the baby blues. It's a severe depression within the first year of giving birth. They use Paxil, Zoloft for it. You want to make sure there's someone to assist with newborn care, and the newborn is never by themselves. They're never alone. Okay. Postpartum psychosis is the most serious, patients are agitated, hyperactive, there's insomnia, they're irrational. Treatment is lithium or other antipsychotic medications. Supervision, again, when caring for other children and anybody in the family, there needs to be supervision, and there may need to be some short-term hospital admissions.
Excuse me, I'm sorry, just to reiterate, you said with postpartum depression, they should never be alone with the newborn?
No, they should not be alone with especially if there's, why?
Psychosis I get, but like depression, I feel like, I don't know.
There should be someone around.
Okay.
Yeah. When why? Tell me why that's so important. I know depression, what's that?
Safety of the child.
It's a safety issue, right? And depression can be across the continuum, right? Can be not across the continuum, but there can be more serious side effects that can pop into play at any time. So they need to be assessed. Psychosis, absolutely. Okay? Older adults, depression is common in older adults. Not a normal part of aging. Clinical manifestations, they have some memory problems, social withdrawal, sleep disturbances, loss of appetite and irritability, more so than usual. Then you will see some of those things happening as you get older. This is an increase. 2 or more stressors can bring on a depressive episode. Medical conditions, polypharmacy, loss of developmental changes, those kind of things all need to come into play. And there's a specific tool used for older adults as far as depression screening. So let's talk about the nursing process. What are your priority problems?
Safety.
Yeah, what else?
What is that?
Anxiety might be, you might have an issue with anxiety. What else? Because they are married again. What else?
Trauma-informed care.
Trauma-informed care. What else? What kind of things are you looking? What other things are you looking at in assessment?
Suicide assessment.
What's that?
Their appearance and how they present.
Absolutely, you're doing a really good assessment. And what else are you thinking about, though?
Ruling out.
Their mood, is there hopelessness? Is there powerlessness? What are their coping skills? Right? Are they at risk for suicide? When you got to the safety, you got right to it. There's a risk for suicide. Okay? Self-esteem could be situational or chronic, depending on where, you know. Health maintenance, probably ineffective, right? If you're depressed, you're not able to take care of yourself. So you want to look at all the sleep, nutrition, all of those kind of things. Bathing. So again, a really good physical assessment, look at the, safety and vegetative symptoms. You want to look at their psychological assessment, mood and affect. You want to look at the suicide severity scale. You want to look at the Columbia suicide severity scale. You want to do the labs that we noted, not in the above slide, in the previous slide. You want to know if they have any other comorbidities with chronic illness and how that's being treated. And you want to look for substance and alcohol use. Implementation. You want to make sure you are emotionally neutral. It's hard to do sometimes, but you want to recognize that, you want to be emotionally neutral. You want to recognize your emotional cognition, how you are feeling about things. You want to assess them for suicide. If they're at a higher risk for suicide, the suicide precautions, low risk, usually home treatment, medication management we talked about. Try to improve self-esteem, and also you want to try to instill hope. And how are you going to do that? Using therapeutic communication. Here we go. So, this is you're going to need to know these for your process recording, right? Before you go into your process recording, you're going to kind of need to know these things, right? And you're going to also need to know the barriers to communication. When you do your process recording, and I'm going to move over just because these are just listed. I do give you the sheets to take with you to clinical, okay? And I'm going to talk, all right, let me start off first. We'll talk about this. You're going to submit it by March 9th. Put it early for you guys to spread it out a little bit, right? You're going to determine who you're going to do it on with your nursing instructor. It's a planned thing. It's not just going in and talking to the patient and saying, I'm going to try to be therapeutic. You're going to plan this out, right? Your clinical instructor is a person who's going to be grading. So she probably, you want to make sure it's with someone, because it's on the medical unit, right? So you want to make sure it's someone who has some type of comorbidity. And there are plenty of patients that you could choose from on the unit that have comorbidities of depression, mind you, right? But there are some other comorbidities we saw quite a few on our unit, and it's everywhere, right? So you want to talk that over with your clinical instructor.
So did you say you want to find someone specifically with a diagnosis of depression?
You should try to find,
recording?
yeah. If you can't, if you're having a hard time, not depression, any mental illness really.
Okay.
Because there is and we're going to look at the rubric together. There is a section where you want to relate the problem to your communication, to what's going on. Make sense? Okay. It won't be that hard, honestly, to find someone with a mental, comorbidity of a mental illness. It won't be that hard, okay? And we have until March 9th, so there's some time, right? Like week to week, but if you find someone quickly, you want to talk to your instructor about it. She's the one who's assigning her. We're going to teach out. You're me on the first level. I'm so excited.
Really?
Yeah. We just hired her. I don't know, men in, right? We need more men in education for sure.
Yeah.
The problem is they go for the higher paying jobs. Whatever, that's a different path right now.
Is there a template posted in Blackboard?
There is a template posted in Blackboard, and I'm going to pull it up. I just want to talk to you about the main stuff, because I want to make sure that you guys feel comfortable doing this, okay? And having your clinical instructor, because the rubric, I really tried to make the rubric and I worked on it with Professor Mobilio and Professor Williams, I want to give them credit as well. And we tried to make it as specific as we can so that you know what you're looking for, okay? Make sense?
Yeah.
Yes. James.
I don't see the process recording in Blackboard.
It's hidden still. I didn't want to freak you guys out. I be worried, you know, I didn't want, when I gave you the alcohol use disorder, you guys were like, oh God, you're giving this to me now. That's why we're really trying, like, I didn't want to give it to you. I will open it up, I promise you. That's where you're gonna submit it, and I'm gonna show it to you on here as well, I promise, okay? So you want to record all of your communication, and you want to make sure it's verbatim. So if you know, when you're talking to your patient, you introduce yourself. You know, is it okay to have, like, you usually ask permission. I want to have a discussion with you for a assignment, whatever, right? You want to be writing as you go, because you want everything verbatim. Or if you can't write, you want to make sure you get right out. Like I always say, okay, write everything down now that was said, because we want to see it verbatim. Because then it's much easier for you to go back and look and say, oh, this is what I use, right? Again, you're going in with a plan before you even talk to the patient. You're looking at those therapeutic communications. Now, do you think you're going to come across a barrier to communication? Even though you go in with a plan for your process recording?
Of course.
Absolutely, we all do it. We all do it, right? You got to note those as well. There has to be some, like you're looking at the setting, you guys have done a process recording in the past?
Yeah.
Yeah, are you comfortable, pretty comfortable with them?
Yes.
I mean, no, but yeah.
You just took a conversation that you had, like you didn't go in and ask for permission, and it's like, what do you want us to talk to them about? Like before, like our process recordings were just like.
You can talk to them about anything that's going on as far as their care. You don't necessarily have to say, you're not going in there, and that's a good point, I'm glad you said that. You're not going in there and saying, hi, I'm Lisa, I'd like to talk to you about your depression. Hi, I'm Lisa. No, you know what I mean?
Yeah.
No, that's a good point. That's a very good point. Anything. They're here, you're just trying to use a therapeutic communication. Okay? When we did COVID, and just to give you an example, when we did COVID, when we all did COVID, when we were, experiencing COVID and it was just online, we had people talk to their family members. It doesn't matter, that's how we did it, because that's all that we had available, right? So you would kind of want to pick someone with a mental illness, a comorbidity of mental illness. Depression is a good one, just because we're doing it right now, and then you can, and you will see a question on therapeutic communication on the exam, I can guarantee you that. So it might, it would be helpful if you can't find someone. I mean, we're not going to say, oh God, you can't find someone. What we're assessing is, was your communication therapeutic? Were there any barriers, and are you able to analyze it? That's a pretty important part of it, right? Some people, like a lot of times, students will not analyze it. Go back and take a look at what the therapeutic, and we're going to get to the case study, and then hopefully you have to do a little bit of that in the case study. That's a long-winded answer, but you got it, right? Okay. All right, so this is all in your book. The copies that I gave you are to take to clinical with you to use, okay? Now, I got to go out again, so please bear with me, because I want to actually pull it up.
I have a question on this.
Sure.
On your rubric, it says identifies illness related to communication pattern. What does that mean?
So that's why I say it helps with, it helps you, whatever the illness is, right? So say depression. They might be withdrawn. Don't forget, communication is verbal and nonverbal, right? So maybe they're withdrawn, maybe they're slow in their responses, maybe they're psychosis, whatever they're saying as far as psychosis. That's going to take you, if it's a different diagnosis, you might have to go back to the book and look at those things, look those things up, but you have to analyze it. Like, what's going on here? So those signs and symptoms.
Somewhere in there that the reason they're talking slow is because of their depression.
Correct.
Because of their.
But you want to use your book. Don't forget, you want to use our book. You want to back it up with the data. What else? What other questions? You guys all have your work in front of you. What other questions do you have? 5 points if you're late. 5 points if you're late. March 9th is a big deal for you, right? This isn't going towards your grade, but you need to get a 70 whatever. You have to have a satisfactory whatever is on there for satisfactory in order to pass clinical. if you do give us, it sounds like me, I don't need to do it that way. I just want to warn you beforehand because I want you to just to be able to hand it in and get it, you know, and get something from it. It's not just about getting a good grade, it's about getting something from the assignment as well. Okay? So if you don't have a satisfactory, you have to hand it in again. You have to change it. You have to make sure that it's satisfactory. That way we know that you're getting, and I feel like a bad guy right now, but that way we know you're getting what you need to get out of the assignment. Make sense? Yes. Okay. You're not happy about it, but it makes sense. Okay. That's what I'm reading. That's what I'm assessing. Okay. Any other questions about the rubric? Yes.
Fully correlates theory to practice by analyzing content and process for the interaction, providing an appropriate reference.
Oh, geez.
That's where you're going back. That's exactly what she asked you about. That's where you're going back. You're putting the theory. Whatever, it's the same. It's really the same thing. Whatever issue there is, you're going back and using a reference for it. So say there's some psychosis going on, right? You go back and you find it even, you could use Pearson or whatever reference, and reference it. Then you want to relate it to.
No, I'm not here.
Oh, okay.
I'm not here.
You want to relate it to what the communication process is. So say they're saying they're delusional, they're bipolar, they have a history of, they're not bipolar, that's bad. It's a patient with bipolar disorder, okay?
Oh, yeah.
Then you relate it to what their communication is. Make sense?
And we're citing sources?
You are citing the source.
Just one is enough?
Yeah.
Okay.
If it says appropriate sources, that's where you're going to put it. Okay. Or you could go on to the next page. It is, you know, there is plenty of space on the actual process recording. I'm going to click onto that. Think about, look it over some more, and let me know if you have more questions as far as that rubric, because I'm going to go out of here. You know how long that takes me. An hour. That's good. Okay, so I'm showing you where this is as well, guys. You know it's the same as last time.
We can't see it.
Oh. How about I go over here? Can you see it now? I gotta get out of that PowerPoint altogether. I did make this one. Yeah. I'm gonna just get rid of it altogether. Do you know your helmet in? Yeah. All right. I got rid of it. it's uploaded to Blackboard by the 9th. Your Pearson references are there. In column 1, you're going to describe the setting. In column 2, and this includes the physical environment, the time of the day, all those things. In column 2, you're going to put your nonverbals and verbal communications. In 4, can you see the? You can see this, right? You're going to describe the communication. Describe your reaction to the communication. That's your feelings. And in 5 is where you're going to analyze it using your therapeutic communication sheets. If you have other therapeutic communication sheets, I believe Professor Fish gave you Barcarollis's as well. If you still have those and want to use those can be used. I'll make sure that the clinical instructors have copies of the Barcarollis. Okay? They're the same. They're very close in nature. Questions? Yes.
So you have to write a little summary after?
The summary we took away because we felt that this was very...
Thank you.
Okay.
Oh, that's very nice.
Well, it was professional. I agree. I was like the 4 minutes. But everything should be in there. So like keeping that in mind, you want to make sure like the whole conversation's in there, and if you analyze it and pull up the things that you need to, you're going to get a good grade. You're going to get a good grade on it, and you won't have to do it again, right? And you'll get the most out of it. Honestly, it is about getting the most out of the interaction. I know you guys did a couple of them already. This is maybe a little bit more. Is it the same?
It's a little bit, yeah, it's the same.
Yeah. Pretty close, right? Yeah. So it's your time to shine. It's your third time, right? I'm sure you're all going to be it's going to be great. Yeah, it's just passing it, right?
Okay, maybe.
And your instructors will give you feedback on, most instructors, I tend to do over, like, the person feedback because I want you to get the most out of the experience. But your instructors will give feedback on it, so.
Yes.
Any questions at all, guys, before we move forward? Oh my God, I'm picking it up again.
So much time. Yeah,
We're gonna get in there and then we're gonna get to the case study, okay? 43? Okay, so 42 is just your evaluation. 42 is your evaluation of your outcomes, and it's exactly right. It's exactly what we had discussed already. Did they or did they not complete those, those tasks, those outcomes? All right, let's do the case study. What we're going to do is we're going to break it up again. Right? You can working groups. I'm going to give you 15 minutes. 15, right? So for the case study, we're breaking it up and we're writing it down here, same as we usually do. You guys are doing 1 and 2.
It's just in the PowerPoint.
You guys are doing 3 and 4. This chunk in here is doing both 5s because there's 2 5s. You're going to do 6. And there's 8 of them altogether. 7 and 8. Everybody know what you're doing as a group? 7. Group. You're the spokesperson, please come down and just give your answers. You don't necessarily need to use this mic because some people don't like to hear themselves, that's fine, but I want you to come down and,
dysrhythmia and bipolar
answer the
too.
questions as well, okay? All right. Number 1.
Thanks. Okay, the clinical manifestations of major depressive disorder: sadness or despair, insomnia or hypersomnia, anhedonia, psychomotor retardation, mood changes, depressed mood observed by others, decreased concentration, thoughts of suicide, weight loss or gain, fatigue. Some of the client symptoms consistent were difficulty getting out of bed, loss of interest, decreased appetite, weight loss, insomnia, and suicidal ideations. 2 was a physical exam. It's important to rule out any other underlying cause of symptoms. Diagnostic tests would include thyroid levels, electrolytes, pregnancy test, liver function, and the last 3, toxicology, blood alcohol, and urinalysis, were all completed on the patient. Because number 3.
Any questions?
Nobody for number 3. All right, so what are your risk factors? You're looking at a 20-year-old, and the question came up as to if the person qualified as 20 years of age qualifies as a risk factor, and it does. Why?
Things like that.
A lot of mental health disorders develop around that age. Adolescence has moved further into young adulthood, just based on what's, isolation, those kind of things, right? And not being able to get out in the economy and get their own, so a lot of adolescence has moved on. And young adulthood is really a risk factor as well, okay? It's early young adulthood. What else? She's female. Rational issues in a prior ideation are all heard the risk factors here. Okay? Relational issues? Yeah. Relationship. She broke up with a boyfriend.
Boyfriend broke up with her.
Or he broke up with her.
Yeah.
Okay. Which makes it worse. No, it is worse. You're right? Because you're absolutely right. He broke up with her. Okay, 4, 3, and 4 were together, correct? So what adverse effects from SSRIs, atypical antidepressants, including the SSRIs, TCAs, and MAOIs? So these are separated out. The SSRIs are insomnia, fatigue, difficulty concentrating, anorexia. MAOIs, hypertensive crisis are the big one, sexual dysfunction. These are right? These are in the SSRIs, the sexual dysfunction as well, serotonin syndrome as well. With the MAOIs, you worry about what? The tyramine, okay? Increased blood pressure, increased heart rate. Tricyclic is agranulocytosis, orthostatic hypotension, and angioedema. And then the SSRIs are really the sexual dysfunction is a big one for them, right? And SJS. Who's 5? Anybody want to come down and talk? Just want to hear me? You can't get enough of me? You're like, we got to go, Professor.
So collaborative interventions, obviously cognitive behavioral therapy, nutritional support, she hasn't been eating, things like that. Talk with a dietitian. Med management, of course. Education on therapeutic range and alcohol. Psych consult, like I said, CBT therapy, family therapy. Suicide watch, possibly. We'd have to ask more questions about her. We know that there's already ideation, but we don't know how far without asking more. History and physical, family history, community support, diagnostic drug screen, therapeutic communication. I thought that said give hug. Give hope.
I was going to say the heart.
Yeah, no, don't give hug. Suicide prevention, safety plan, alternative therapies, exercise, acupuncture, things like that. Vitamins, and obviously obviously asking more about the suicidal thoughts, which leads to 5B. On the rating, based on the information we have, we can't really give a rating. Maybe low, could be moderate, but we need to get more information. We have to ask more questions. She's yes to ideation, but there's lots of other questions that we can ask about that. Have they thought about how they're going to do it? Have they gotten any tools in order to complete it? Lots of other things. So we can't really label it without knowing more.
And your intervention is related on the Columbia Suicide Severity Scale. You can't get to there to see what you're going to do in relationship to what's on your case study. What I really want you to concentrate on is the fact that you need to ask all those questions on the Columbia Suicide Severity Scale. Thank you, Ryan.
Yep.
Who's 6?
Could have done that.
James, you can do it from there if you want. You can read it from there if you want. Come on down. Come on down, James.
All right, bring it.
Like the person's right.
Da-da-da. That's gonna be me at the end of the semester. With the spaghetti.
Yeah.
Annie for
Kudos.
Yay.
So then we have Amy. She's depressed. She's very tearful. Insomnia. She has delayed verbal responses, not making any eye contact, can't concentrate, doing poorly in school. She's disheveled, her clothes are like all wrinkly. She has weight loss from her poor appetite, socially isolated, psychomotor delay. And then just in general, she has a headache, she's agitated, she has some GI distress, difficulty getting out of bed, significant impairment of social and academic symptoms. So this is Jamie.
Good job. Very nice. Where do you want her? Where should I put her? Here comes Katie. You don't wait for you, Katie.
Okay, so ours were to find the barriers in communication. So we started out by saying, "Hi, Miss Satter. My name's Sally. How are you feeling today?" She came out with a challenging method, said, "Lousy, just lousy. I did not sleep last night. My stomach is killing me." So instead of us passing judgment by saying, "Oh, that's too bad. Have you had any breakfast?" we would say, "Describe more about how you're feeling." Her response, challenging again, "No, I didn't say."
That's good. What is this? What kind of statement is this?
Open-ended.
It's open-ended. Right? It's not yes or no. What else is it doing?
Assessing further.
It's part of your assessment. It's kind of it's seeking clarification as well. All right? Good. Go ahead.
So then the patient said back, "No, didn't I say my stomach is killing me?" Again, that's challenging. And initially, our response would be giving common advice, which would be maybe eating would help your stomach pain. So instead of that, we would say, "What do you normally eat for breakfast? Have you experienced this in the past? What helps?" Then she responded again with a defensive comment, which you don't know anything about my pain, and rejects us by getting up and walking away. So, I have this also. What is the quality, frequency, severity, timing of your pain?
So open-ended and part of your assessment.
So in response to her last one, we would say, "I'd like to help you. Please tell me more about your pain and how you're feeling." So she hopefully doesn't reject us.
Excellent. What do you think could have been better in the very beginning? Not from what the person was saying. You guys have your thing. How
how did the person come across? How did the nurse come across in the very beginning? We're talking about barriers, right? So how did the person come across in the very beginning?
Not really caring too much, like, well, that's too.
Correct, and even her introduction, she went right to a question, open-ended question. Like you can have an open-ended question, but in the wrong spot, right? That's also something that you got to consider as far as barriers, right? Your introduction should be your introduction. You're meeting someone, right? Your introduction can be therapeutic or non-therapeutic. You want to just say, "Hi, my name is Lisa. I'd like to have a conversation with you. Do you have,
Well, and it felt like she had already decided what was wrong with it.
Exactly, and that's what I think Sam was getting at as well, right? So when you do this type of communication in place, that opens up, right? When you're doing assessment kind of things, so what does it tell the patient when you're talking like that? What does that say to the patient?
I'm not listening.
When you talk for the barriers, right? But they're open-ended questions. You want to know what's going on. You want to get an assessment and you want to get something done. That's the nursing process, right? That's what you're telling the patient. You're telling the patient you care about what they're saying. That's therapeutic communication in a nutshell, right? It's trying to convey you care about what they're saying and get to what you need to get as far as, your goal. Good job.
I'll go. Can I take your?
You can stay right there.
So for the first part, the nurse uses introduction, building trust, and rapport with the patient. For her second statement, she's offering herself and providing general aid, asking if the patient would like to talk. For her third statement, she's exploring, perception checking, and seeking consensual validation, seeing if the patient wants to talk. For her fourth statement, she's restating and sharing an observation because the patient thinks. For her fifth, she's seeking clarification, reflecting, and asking an open-ended question. For her sixth, she's again building rapport with the patient by seeing if she can offer her something to help with her stomach pain. And then for her final statement, she is summarizing and
What do you guys think about that? Are there multiple therapeutic techniques here?
Yeah.
Yeah, but you can't, they all qualify, they're all good. That's pretty, we had a couple extra ones now, so that's good. You guys, the point of this at the end here about the therapeutic communication, I'm just looking at it in general, is to help you understand that you've done this twice. You know the information, this is not gonna be a difficult assignment for you. You know it, okay? Good job, very nice job.
Thank you.